This is a 47-year-old female with a history of several months of increasing hip pain. She didn't really have any frank mechanical or rotational injury. Pain just sort of gradually became worse and worse, and at this point she's almost, she's using crutches most of the time for ambulation, so very painful, and a lot of mechanical symptoms. We can kind of see here on the femoral head there's a lot of delamination, early arthritic changes, and as we get into the labrum, the tissue here is fairly degenerative. We can see a lot of yellow sort of degenerative changes, and a lot of times this tissue is not very supportive of a labral repair. We'll trim some of it back and see if when we're left with the tissue, then is there enough to repair here. So we're going to come in behind the tear. There's already a tear there, so this is probably a better way to resect if we have the angle. I think based on the amount of tissue that's left here, I think what we'll probably do is put an anchor in the face to try to stabilize. The problem with the dysplastics with taking a lot of the labrum is that they depend on that labrum to some extent for their hip stability, and if we're too aggressive with the resection, sometimes we'll actually get a quick acceleration of whatever degenerative process they have ongoing in their hip. So sometimes we have to be a little bit more conservative with the resection on these patients, even though this is not the healthiest tissue. So we have a pretty good amount of tissue here. What we'll do is let's look more posteriorly here. We're going to do a little bit more of a complete diagnostic so we can see the tear stops around here. Shot, please. So that's fairly posteriorly. That's probably about the 10 o'clock position. This is probably about the 12 o'clock position. Shot, please. And then this is probably about the 2 o'clock position. Shot there. So the tear is fairly extensive. She's a little bit older. I think she's got a fair amount of degenerative changes, but I'm a little concerned that taking out the labrum on her is not the right answer. So we'll try to preserve it, knowing that there may be a chance that she may not heal this effectively, or the tissue certainly doesn't look normal, but it should be fairly vascular in that region. This is the hip-specific guide for the 3.5 millimeter push lock. So now I've inserted my trocar behind the labrum. And what I want to try to do is try to get a good angle at this. It's going to be, at first, a little bit, if we pull back on this trocar and walk our way around. So the angle that I was trying to do that repair wasn't really ideal. So I'm going to try to approach it from a little bit more of a direct trajectory towards the acetabulum. So this is going to be a little bit more direct approach probably to the labrum. Once I'm in there, then I can pull my guide wire back, and then we'll go in with a slotted cannula and see if our angle of approach is better. So I'm going to pull my slotted cannula out so I've got a little bit more mobility, and then I'm going to go ahead and we're going to do a drill. Much better angle of approach here. Make sure that there's not going to be any sliding here, and it looks like it wants to slide, so I have to be very careful as I start. Shot, please. So I like to do it about halfway to make sure that we haven't really moved. And we bottom out the drill. Then we drill our hole, and we've bottomed it out. Now we can see that at the articular chondral junction here. So we're going to leave this in place. Then we're going to go back into our anterior portal again. We're going to reposition a guide wire here. We've got fairly tight access. These two portals are a little collinear, so I'm going to save that portal with my guide wire, and now I'm going to go back in to find my anterior portal once again, which is over here. So I'm going to come up, we'll take the slotted cannula once again, and then we're going to pass our suture. So what we've done is we've prepared a rosette of suture material. We're going to pass it right immediately posterior, so right in that interval where we were previously. You can see we've got a large amount of that fiber wire material, and when we open our loop, we've got a significant amount of this fiber wire that stays within the joint. And then we're going to go on the other side of it, and it's simple. Once we have this much suture, we simply grab any of the loops here and then pass the suture circumferentially around. Once we grab the loop and pull on the two tails, we slide the loop in, creating a cinch knot. And now we've got very solid tissue that we can grab. So we're going to put our slotted cannula back through the accessory portal that I created earlier. We're going to take the anterior cannula out and leave a guide wire in place. And then we're going to slide since we've drilled from the accessory portal, we need to put our anchor in from the accessory portal. You don't want to diverge with these anchors. What we've done is we put both of the loops from the cinch inside a knot pusher here. We're going to deliver some of that suture material out here so I can grab it. And then through the accessory portal, we're going to come down and grab the suture, but we have to grab it distally. Otherwise, we can't pull the knot pusher out of the way. So now we're going to pull the knot pusher out, and I've got good control of this. Now I'm going to deliver my 2 loops of suture out through my more lateral portal. Now we're going to prepare the anchor. This is the 3.5 millimeter push lock anchor, which is a PEEK material. So it's polyethylene material, which is non-absorbable, but also, probably more importantly for this patient down the road, is it's not radiographic at all. So now we've got our cinch stitch in place and the anchor is ready to go. And one of the tricks here is to make sure that we don't have any kind of convolution. So I'm going to deliver it into the joint and make sure that I know my angle of how I'm going to deliver this device. And so now we need to play around with the rotation of the sutures to make sure that we don't twist these as we advance. So good control of it here. We'll deliver a little bit more of it now that I've got my rotation figured out. We're going to walk our anchor over to our drill hole. So as we advance, very carefully, taking great care not to diverge in any way. Shot, please. So we want to make sure that we're in the same entry and at the same angle. We're going to advance our anchor into the tunnel and make sure that we've got sufficient tension on the construct here. And the key part is to sink. There's a small black line that you can just barely see at the edge of the entry there. So I know I'm advanced enough so that my suture is not going to advance along the shaft of the outer core here. Shot, please. We want to make sure that we're deep within the tunnel. There's no divergence, no obliquity to that wire at this point. Shot, please. And then the way we disengage the device is we rotate it counterclockwise 6 to 7 times. And once we've done that amount of time, that disengages the threaded device at the tip. And now we pull it out. We've got our knot cutter. And so this is the finished repair. And what we'll do is we'll probe it. So now we've got a very nice, stable, more medial aspect. And it actually brings back a fair amount of this labral tissue. We've taken it, there's a fair amount of vascularity here. There really isn't enough space, I don't think, or angle to really get a second anchor. So I think one anchor is probably sufficient and really preserves her perilabral circumferential fibers. And we've got nice, stable, little bit of degenerative tissue here. But for the most part, her labrum is very nicely stabilized.